Okay, so this is it's sort of an overview of two cases, and I probably could have come up with some more, but I just, for brevity's sake, just came up with two cases to kind of emphasize this point. But this is a really, really basic skill that I think if you were in my class, you heard me talk about it all the time. But I think that in practice, we need to use it more often. And I've titled this Hands Are Important. So, as I said, and as I always say, this is very informal. If you have questions, please stop me. I am going to just present the cases, but we can discuss throughout. So, as I go through it, if you have questions, if I didn't give enough detail, just ask. All right, so case number one is baby G. This was a 30-year-old mom, G1P1. She had hypothyroid 1 year ago, and she was on meds 1 year ago, but now she's okay and not on meds. She had no infertility. She did have breast changes in pregnancy. There were no complications after the delivery, and she goes back to work in 3 months. The baby was born via C-section for failure to progress at 40 and 5 weeks. The baby did do skin to skin after birth and was latching okay, but was pretty sleepy in the hospital. Mom said she was pressured into giving formula twice in the hospital because baby has to eat. Because he was sleepy, and that's normal, and that's what we see in early babies, especially after a long induction turned C-section. Those babies are very, very sleepy. The birth weight was 8 pounds, 8.5 ounces. So I saw this kid for the first time at 11 days, and he was down 6.5%. We generally say that weight loss is normal. We know that. We have research to support that, but the babies don't generally start gaining until the milk comes in. Milk came in appropriately around day 3 with this mom. But at day 11, baby was not gaining. And we expect babies to be back to birth weight between 10 and 14 days. And at 11 days, this baby was down still 6.5%. So not awesome. Mom told me baby breastfed about every 2 hours, but only one side. He was very sleepy and she couldn't get him to nurse the other side. Diaper output was appropriate, so a minimum of 3 stools. And when I did a weighted feed, the baby transferred 35 mLs from one side. So I pulled up my calculator and I showed her, this is how much your baby should be getting, which obviously is not 35 mLs, it's closer to 60. So then we put the baby on the other side and he got 60 total. So I re-emphasized how important it is to offer the second breast at every feeding. So the plan of care for this visit is to offer both breasts at every feeding. I told her sometimes babies take a break between sides. Sometimes they want to take like 15 or 20-minute nap. So maybe if the baby is awake and alert and ready to feed for the first breast, you just put them on. And then after the first breast, you want to change the diaper and try to wake him up again so that you can get him to do that second breast. Instead of doing the diaper change first, maybe do it between the breast. The other thing I didn't put here in the plan of care, but if you've heard me talk about cases before, I always say this, is we want to kind of stimulate baby and keep him active and only leave him on the breast as long as they're active. So mom doesn't need to let the baby stay on if he's just doing these quick, non-nutritive until he finally lets go of the breast. That's not productive. It's more important that she stimulates him and reminds him to keep going and then takes him off when he's no longer active. So that was the plan of care. And I saw her on a Tuesday and she was going back to the provider I saw her on a Monday. And she was going back to the provider on a Thursday. So I wanted to see her quickly so that we could tweak the plan if we needed to, so that we could get back to a better spot. Because she said that the provider expected that the baby was back to birth weight by Thursday at that visit. And she was feeling really pressured by that. So I saw her 24 hours later, and the baby was, this isn't right. This should be 12 days. I saw, and he had lost 5 grams. So even though he was nursing on both breasts for the last 24 hours. And she said he was actually sleeping better because before she wasn't able to put him down between feedings, and now she was. But because he lost 5 grams, I'm like, we have to do something different here. And even at this feeding, he only transferred 45 mLs at the breast. So I'm like, okay, we got to do something different. So I said, in addition to offering both breasts at every feeding, we need to add breast compression throughout the feeding. So I taught her how to do that and showed her when you're doing that compression, you'll see he starts doing more swallows. We really practice listening for those swallows. So that was the plan. She was going to do that until her visit, and then I was going to follow up with her after the visit. So she went to the pediatrician, and he had gained a little bit, and they were happy. He wasn't back at birth weight, but they were happy with his growth. So I saw her, I ended up seeing her a couple days after the visit. It was tricky on Halloween. So I ended up seeing her on Saturday. And the baby had gained 6 ounces since the last visit because of the breast compression. And when I saw her at that visit, he transferred 75. So if you remember the very first visit, he transferred 35 from one breast, but 60 total. Then we added the breast compression and he jumped up to 75. So this kid made great progress just by adding breast compression. That was it. We weren't like supplementing or doing anything different. It was really just about adding that breast compression. I should also say this kid doesn't have any tongue tie. There's no oral restrictions or anything weird. He did, if you can see me, when I looked at him upside down, because I was doing a little bit of craniosacral therapy on him, his jaw line was not symmetrical. So it kind of looked like maybe he was stuck in the birth canal just a little bit asynclitic, and there was a little bit of just elongation on one side. Most of you probably wouldn't notice that. It was very, very subtle. But I did talk to the mom about how body work can help. And she was like, how about a chiropractor? Should I take him to a chiropractor? And I said, yes, absolutely. She did take him to a chiropractor, and they were like, oh, yeah, he's really stiff on one side, which supported what I said to her. So the plan of care is to continue doing what she's doing, offering both breast, doing breast compression throughout the feeding to facilitate milk transfer. I taught her to look for those swallows, to take the baby off when he's no longer active. And then we're going to follow up in 1 week to start introducing that bottle because she does have to return to work. So nothing really major that stood out for why this baby wasn't transferring milk great in the beginning. It was just that, you know, he was kind of sleepy and he just needed a little bit of extra help with milk transfer, which is not uncommon. And I see it very often. So case number 2, baby N, was born to a 37-year-old G2P2. This mom breastfed her first baby for 18 months with no real problems other than kind of like getting off to a rough start in the beginning. No infertility, no thyroid, and she's like a business owner but works from home, so she's not really going back to work. When the baby was born via normal spontaneous vaginal delivery at 39 and 5. The birth weight was 7.3. Skin to skin and nursing while in the hospital. They went home like right at 24 hours. But when I saw her at 4 days, this kid was down 11%. Because they were like, oh, she's a multip. She knows what she's doing. They didn't have great follow-up. Baby lost a lot of weight. She also forgot that we need to wake up babies pretty frequently, wake up newborns. And this is not uncommon. We see this a lot with multips, that they forget that newborns need to wake up frequently. So she was only feeding the baby every 3 to 4 hours, which is not enough in 24 hours. She said she was attempting to do both sides, but baby was pretty sleepy, so that wasn't really happening. Okay, low diaper output. It wasn't awesome, and there were a little bit of urates. But look at the transfer. It was not good. A 4-day-old taking 15 mLs is low. We would expect a 4-day-old to take more than that. So the milk came in appropriately. The baby was just kind of putting around. I don't want to call the baby lazy. I'm just going to say that, they're new here and sometimes they need a little help. So my plan of care is offer both breasts at every feeding, do the same sort of thing, wake up the baby in between sides, maybe change her diaper in between instead of before the feeding to help wake her up, and then come back in 24 hours. So I came back the next day and the baby had gained a little bit. So that was a good sign. The breast increased, doubled because she was waking the baby up. But we're still down 8% at 5 days, and we're not really gaining much yet. So we have to tweak this. So the plan for after visit 2 is to add that breast compression. I want her to add that. And she saw it immediately. As soon as she started doing that compression and the baby started gulping, she was like, oh my gosh, I guess I need to do this. I'm like, yes, we need to do this. So I follow up in 24 hours and look how much the baby was 2 days, the day before she was down 8% and now she's down 6%. Just by adding that breast compression, that made such a significant difference. So baby transferred 35 at this visit, but she had been doing well. The diaper output went up dramatically. She was doing really great. So the plan of care is to offer both breasts at every feeding, do the compression throughout the feeding to facilitate milk transfer, and follow up in 5 days. At 11 days, the kid was over birth weight. So it was a really quick turnaround once we added that breast compression. And look, at 11 days, the baby transferred 3 ounces. So really, really amazing. So let's talk for a minute about breast compression. The plan of care was the same. Continue to do this, follow up as needed. So let's talk about breast compression. Hands-on breastfeeding is often essential in those early days. And we have to think about, even in the absence of some kind of oral restriction, there's a lot of micro restrictions that can happen due to the position in the womb, due to the birthing process, whether it's a vaginal or a C-section, that can inhibit what happens with the baby's suck, swallow, breathe. I have done 2 training sessions of craniosacral therapy now, and I have learned so much, and I definitely am really starting to see how important this is in every case. But the point of this is that even if you don't understand all of the nuances of that, just thinking that the muscles in the baby's cheeks and most newborns don't have really awesome fat pads yet. And the fat pads really play a role in helping the baby stay attached to the breast. This orbicularis oris that goes around their mouth helps them attach to the breast. The tongue may be a little bit discoordinated because of labor medications or if there's any of those sort of micro restrictions. So it is, even if you don't see a really obvious restriction, most babies will benefit, or maybe all babies will benefit from hands-on compression in those early days to facilitate milk transfer. And I can't give you any kind of this is how many days or weeks you need to do this, because we don't have any published research. We don't even have case studies about it, unfortunately. But I've seen it work, and I really teach it to all of my students because it can make a big difference. When you add that compression, you're essentially forcing milk into their mouth. So if they're just warm and cozy at the breast and just kind of doing a little bit of this and not working very hard, and you add some compression, they go, oh, there's some more milk. And then they can take in more milk per feeding with a little bit less effort. And it works. It really works. So I usually, when I teach it to my patients, I also send them a video. I'll put it in the chat, the video that I usually send, but I want to show you guys this other video by Dr. Jack Newman. He is part of the Canadian Breastfeeding Association. He was like the first male IBCLC. but you can see, I like this video because you can see when he adds that compression, the baby starts gulping. So let's see if I can show you this. This isn't it yet. She's not doing it yet.
And if she doesn't drink, squeeze. There. There. There's the pause. There. 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 And so keep the pressure up until it doesn't work and then release. Wait for her to start sucking. And if she doesn't drink, then squeeze. See how that works to get her more milk. There. 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 Good. And then release when it doesn't work. She'll start sucking her own when she tastes a bit of milk. And again, if she doesn't start drinking, then squeeze. This is the way to get that extra high milk into her so that she maybe drinks more on this side, then it'll save one latch per feeding. Mm-hmm.
Now, I'm definitely not promoting that we only do one side by adding the compression. But as he said, the babies are going to transfer more milk. And if we think about how the fat in the breast is sticky and it sticks to all the milk making parts, if we're adding compression, we're going to get more fat per feeding. So those babies are going to get more volume plus higher calorie milk, which is going to help with the milk, with the weight gain. So that is a video I think is really helpful for professionals. I don't send that one to parents because I feel like it's a little much. But the one that I send to parents, which I'll share with you guys, is showing the mom how to do it herself, adding that compression and showing her, look, now the baby's doing more gulping. So it can be so helpful. So I want to hear from you guys. What are your questions and what have you seen it work?